Hello, thank you very much. I'm Heather Siefkes, and thank you for having me here today to share my work on critical congenital heart disease screening with machine learning pulse oximetry. The work I'm presenting today is funded by the sponsors listed here, and I also want to disclose that I am listed as an inventor on a patent filed by UC Davis regarding some of the technology that I'll be discussing today. And I'm also the founding member of a company called Neopose, a company aimed at improving the detection of critical congenital heart disease. So when we discuss critical congenital heart disease screening, we have to acknowledge this landmark paper by Anne DeWall-Granelli from 2009. And I first want to start with a few definitions. When I say critical congenital heart disease, or CCHD, I'm referring to an anatomical heart defect that requires surgery or catheter-based intervention in the first 30 days after birth. These infants are generally quite ill and require intensive care therapy leading up to that surgery or procedure, and therefore it's very important that we diagnose them before they go home from the hospital. However, prior to Granelli's work and before universal pulse ox screening, 25% of infants with CCHD went home from the hospital undiagnosed, and another 5% were diagnosed at autopsy. In Granelli's work, they found that adding oxygen saturation, just a little Band-Aid with a red light to the hand and the foot, improved our detection of CCHD from 63% to 83%. And the false positive rate from the pulse ox component was quite low, less than 1%, which is very important when we're talking about a universal screening test for newborns that requires an immediate action and seeking cardiac evaluation. And since her work, the use of pulse oximetry screening for CCHD has expanded throughout the world. And I imagine there's countries that are more colored now from this map, as this map is even a few years old already. And since then, we've also learned that CCHD screening with oxygen saturation is best at detecting defects that have impaired blood flow to the lungs. Overall, it detects about 3/4 of CCHD, but again, best at those that have impaired blood flow to the lungs, such as transposition of the great arteries as shown here. In transposition of the great arteries, the vessels that come off of the heart are swapped or transposed such that any blue blood coming back to the heart never goes to the lungs and instead goes back out to the body, resulting in a low oxygen saturation. However, in defects like coarctation of the aorta that have impaired blood flow to the body, oxygen saturation screening only detects about 1/3 of them. And in fact, it's estimated that despite universal pulse oximetry screening, that we would miss nearly 900 babies with CCHD in the US every year. And the vast majority of those missed have a defect like coarctation of the aorta. And unfortunately, coarctation of the aorta is the most common critical congenital heart defect, and it accounts for 1/3 of deaths due to a late diagnosis of a critical heart defect. Thankfully, there's additional data that can be measured by pulse oximetry that can improve CCHD detection. That data, however, goes unused. It is not clinically applicable in its current state, and further research is needed on them. I'm going to go through each one of those individually. The first I'd like to discuss is perfusion index or pulse amplitude index. It's probably the one you've heard of the most, and it's essentially the ratio of the constant absorbed light, so the absorbed light of like your skin, your muscle, your venous blood flow, versus the alternating absorbed light or the arterial blood flow. It's basically the amplitude of the pulse oximetry waveform, and it's a measurement of pulsatile blood flow that is independent of oxygenation. We can also measure heart rate or heart rate variability by simply measuring the pulse from the pulse oximetry. And when you have two probes in place at a time, such as on the right hand and on the foot, we can measure something called radial femoral delay or pulse delay. It's essentially the time difference from the pulse arriving in the hand versus the time of the pulse arriving on the foot. We can also measure the rise and the fall or the slope of the pulsatile components of the waveform. All of these pulse oximetry features have been found to be abnormal in newborns with CCHD. And in fact, all of them, other than heart rate variability, have also been found to be abnormal in infants with coarctation of the aorta. I'm going to discuss one of them a little bit further, which is perfusion index. And that's, again, it's one you most likely have heard about already, and the most research has been done on this. So 2 years prior to that landmark study by Anne Granelli, she also published some work on perfusion index, establishing a range of normal in 10,000 healthy newborns and newborns with left-sided obstructions like coarctation of the aorta. And what they found is that infants with defects like coarctation of the aorta had perfusion index values that all fell below the interquartile range compared to the infants that were normal. And then over half of the infants with a coarctation of the aorta had values that were less than the 5th percentile. So approximately 10 years later, I essentially repeated Granelli's work on perfusion index, but on a much smaller scale. But I also included newborns with all types of congenital heart disease and also included more infants with congenital heart disease. And in this, we found that the addition of perfusion index to oxygen saturation improved the detection of defects like coarctation of the aorta from 20% to 80%. This, however, was still a small sample size. And unfortunately, we saw that our false positive rate was over 2%, which for a point of care screening tool is still too high, as I mentioned earlier. Now, while my work or my version of this study was not particularly novel or large, it did give me some useful pilot data, but then more importantly, it gave me some potential insight as to why the work with perfusion index didn't go beyond the study I showed you from Granelli. I'm going to show you that here. So this is a video not from my pilot data, but from my current pulse oximetry data collection process, but it'll show you the point I want to make. And so what you see here, hopefully this video is playing for you, you can see a hand pulse oximetry waveform on the top and then a foot on the bottom. You see the oxygen saturation value stays quite stable in both of these with minimal changes. However, the pulse amplitude index or the perfusion index, the PAI, in both the hand and the foot, those values change quite a bit, even when you have time periods without artifact in the waveform. So the issue with perfusion index is that it's so variable that if it were introduced in the same manner of oxygen saturation and screening, which is for the most part a clinician writing down a single number in a moment in time, my worry was that if it was introduced that way, it'd be very error prone. And then also it might not reflect the true physiology because it is so variable. I also just want to remind you of these other pulse oximetry features that I mentioned were abnormal in newborns with CCHD. All of these previously have been studied individually, when it might be a combination of these that is best for screening, but then we also don't know which combination of these. And then also, these would be potential to be, impacted by artifact and also error prone if they also only did one measurement in time as opposed to a longer measurement when introduced as a screening method. So that brings me to my most recent work, in which I set out to answer the question, does dual limb automated algorithm that combines pulse oximetry features improve the detection of CCHD? And specifically, does it improve the detection of coarctation of the aorta? So for a little over 2 years, I ran a 6-site multi-center study. We just completed our enrollment earlier this year after enrolling over 300 healthy controls and over 200 newborns with congenital heart disease, of which we have since confirmed that 135 of them had a critical congenital heart defect and nearly 30 had a coarctation of the aorta. In these infants, we recorded 5-minute dual limb pulse oximetry recording, and we recorded them up to 3 times in each infant during the first 24 hours of life, the second 24 hours, and then again after 48 hours. But not all infants had all 3 of these measurements. These were just the time periods when we tried to capture as many as we could. So as for our methods, I want to make sure it's understood. We were not testing our algorithm in situ. We were recording this data, and then we developed and tested the algorithm after the fact. And we did that with machine learning methods. We used 5-fold validation. We split all of the data into 80-20 random splits for testing and training. Our process has included some supervised as well as some semi-supervised machine learning. And then we used recursive feature elimination for our feature selection. And I'll explain this further as to how that helped us. We also did follow-up to at least 6 weeks, particularly with those infants that were enrolled as a presumably healthy infant, to ensure that they were later diagnosed with a missed diagnosis of a heart defect, which we had quite good follow-up with only 10 patients and less than 2% that were lost to follow-up. So to describe some of these machine learning methods that we use, I'm actually showing you some data that's from an earlier stage in our study. So that recursive feature elimination. So because specificity is so important with this point of care testing in newborns, we use recursive feature elimination to dial in the specificity to essentially perfect, and then find which combination and approach gives us the optimal sensitivity. So as you can see here, at this point in time, we found with random forest and 11 features gave us the best sensitivity while maintaining specificity. I also want to note that at this point in time, we had only enrolled 27 infants who had a critical congenital heart defect with a measurement done within the first 48 hours of age. So we actually combined the measurements during this time period for this analysis. Just to describe a random forest method to you, I want to note that, as you can see at the very top of this plot, the oxygen saturation still played a major role as a feature for our algorithm. However, there was still noted to be some benefit from both the heart rate and the pulse amplitude index. Now, at this earlier stage, we did not include the pulse delay or the slope from the waveform. And the reason for that is that in order to incorporate these features, you need not only artifact-free data, but you need artifact-free waveforms. So these may look like drawings, but they're actual pulse ox waveforms from our patients and artifact-free time periods. So we then turned to creating another machine learning pipeline that in order to find the artifact and remove it from the entire waveform. So while some artifacts are obvious to the eye, others might not be so obvious. So both of these pink sections are showing an artifact, which the one on your right, you might think that doesn't really look like an artifact when you're looking at just this short piece of the waveform. But when you take the entire waveform into consideration, it then becomes more obvious that, that it's an artifact. So this is the point where we used semi-supervised machine learning methods, which what that means is that we used a partially labeled data set. We had hours of waveforms that were annotated for artifact. And just to highlight how difficult it can be to determine artifact versus not, even our annotators disagreed on 12% of the beats as to which was artifact versus not. Now, I'm not going to go into more detail on our methods for this aspect, but if you do want to learn more about the machine learning methods we use for this artifact detection, please refer to this reference here. But I do want to note that this is the method that we then later use in our current CCHD screening algorithm to help us clean out the artifact and use the clean components only. And it performed quite well and had a 78% of the intersection over union, meaning it identified 78% of the total waveform as correctly classified as artifact versus not. And by doing this, we were then able to look at those slopes and pulse delays more. And what I'm showing you here are some slope and delay and pulse delay calculations for infants with critical congenital heart disease, coarctation of the aorta, and then those that were healthy. And I'm showing them for you going down for those 3 different time points. And what I want you to see is that just looking at them, you can see there's a change in the values over time. And that direction of change is different in an infant with coarctation of the aorta getting bigger versus a healthy baby is getting smaller. And this was not the first time that we encountered this idea of values changing over time in these infants. And in fact, it might be one moment in time might not be the best screening tool, but instead how these values change with time might be better. So what I'm showing you here are overlapping hand and foot waveforms from an earlier stage in our study as well. And on the box on the left is from a normal newborn, and then on the two on the right are from a newborn with a critical coarctation of the aorta while that baby was being weaned off of prostaglandin therapy. So prostaglandin therapy that keeps a vessel open to allow blood flow past the obstruction. So they're trialing to see whether or not this infant did in fact have a coarctation of the aorta. So I want to draw your attention to is the green waveform, which is showing you the perfusion index in the foot. And as that baby gets further off of that medication, the perfusion in the foot gets lower. And then also you can see that the pulse delay, the further the baby gets off of the medication, that pulse delay also increases. Unfortunately, and interestingly, this baby had a confirmatory echocardiogram when the baby was off of the prostaglandins that didn't think that there was a significant coarctation, and the baby was discharged, albeit very thankfully with very close follow-up, as the baby did in fact have a critical defect of the aorta, needing surgery during the second week of life. So up to this point, I've shared with you kind of our process through the study and some things that we learned along the way. And now I want to transition into showing you our latest machine learning algorithm results and how it compares to oxygen saturation alone screen. I want to first have you note that the ends you'll see in this are going to be smaller than that total enrollment I told you we had. And the reason for that is because not all of the infants had all of the time periods of their pulse oximetry collected. And we only compared patients with, if they kind of essentially fell into both buckets of having those time periods all collected. So when we defined our oxygen saturation results, this is the algorithm that we use, which is the most recent from Martin et al. From 2020, which this change resulted in both the hand and the foot threshold being 95% or better to pass, and then this one only allowing up to 1 repeat as opposed to 2 repeats. So we applied this algorithm to the oxygen saturation measurements we had at the time of our data collection for each infant. I actually applied this algorithm for both if we did have a measurement in the first 24 hours and then also after 24 hours, which that's the one we use as our reference, since that's the most common approach done for CCHD screening by oxygen saturation. So just noting the column there, the oxygen saturation would have only detected just under 68% of our infants with CCHD. I want to note here that our specificity at 95%, that is much lower than the actual reported specificity of oxygen saturation screening. But the reason for this is because if our last result available would have meant as a repeat for this algorithm, and if we didn't have that repeat, because again, this is a convenience timing of when we did these measurements, then we conservatively assigned that patient a fail, therefore biasing towards CCHD detection. Now I'm going to show you our machine learning results, but first I'm going to show you a few different machine learning algorithms, and I want to show you how these are going to differ. So this first difference is going to be whether or not that pulse delay was included or not. And so then you'll see that these arrows are connecting down to a smaller N between the ones that did have the pulse included. So partway through our study, we noticed that our pulse oximetry timestamps were not initially providing us with granular enough data in order to accurately calculate that pulse delay. And then we fixed that to have more granular data. So that's why not all of our patients have data that allows us to do that pulse delay accurately. And then the other difference between the algorithms is you're going to see that idea of a single moment in time measurement versus 2 measurements and how these numbers change over time as part of the screen. So to first show you the results that did not include the pulse delay. Both the single as well as 2 measurements improved the detection of CCHD as well as the detection of coarctation of the aorta. However, not statistically significant, but this is a small sample. But we do see that the merged 2 measurements, we start to approach statistical significance and detecting nearly 84% of infants with CCHD. We also achieved 100% specificity with this machine learning algorithm. When we then add in the delay, And again, a merged measurement. We detected 93% of infants with CCHD, and this did reach statistical significance, even on a small sample size. And we also improved the detection of coarctation of the aorta and maintain 100% specificity. This current data pipeline that we were able to create, all of these steps leading up to this point, where we now have a data pipeline where we can collect pulse oximetry data, process it, segment it, extract the features that are associated with artifact, apply our artifact detection algorithm to clean it, and then feed in the cleaned waveforms to our CCHD detection model, and then assign a baby a pass or a fail. Which brings us to, where do we go to next? Well, this algorithm needs to be tested in situ. We need to have a true holdout cohort where we record the pulse oximetry, feed it through that pipeline that I just showed you, and assign a baby a pass or fail in that moment. Because we identified this potential improvement with doing more than one measurement, that also gives us an opportunity to create a dynamic machine learning model that adds new patient data to it, and then potentially adjust the predicted outcome as data is added into it. Some additional work, I'm also currently doing a study assessing pulse oximetry oxygen saturation accuracy relative to skin pigmentation in newborns. There's some recent concerns about the potential inaccuracy of this. But that also allows us to introduce skin pigmentation into our congenital heart disease data pipeline to see if that potentially makes a difference on our screening algorithm as well. So in the end, my research, I hope, helps to advance the newborn screening research, as well as the work for the Newborn Screening Translational Research Network, by improving the detection of CCHD and by creating data pipelines for point-of-care newborn screening. There are so many people I have to thank, and that has contributed to this work, from my mentors, co-investigators, students, coordinators, tech team, collaborators. This has really been a big group effort. I have several references here that I've presented today, and I'd be happy to take any questions.